Okay, so it's going to be streaming in. So I'm just going to. Okay, now I'm going to go live for the webinar now. It's all, yep. Is everyone ready? Yep.
Hello. Hello and welcome to the International Longevity Center Global Alliance webinar. Why Gender Matters, Exploring the Impact of Gender on Health and Well-being in an Aging World, supported by the ILC Global Alliance Gender and Aging Committee. My name is Susana Harding. I'm the Senior Director at ILC Singapore, one of the 4 initiatives of SAO Foundation. Thank you all for joining us today. We are delighted to have with us over 134 participants, including representatives from civil societies, research institutions, the academe, multilateral organizations, and government ministries. Our main speaker will share her study of the global gender differences on health and well-being in late life. Her presentation will be followed by speakers from the Netherlands, United Kingdom, South Africa, Singapore, and Australia, who will share on their country situations. Afterwards, during the Q&A, we aim to have a discussion on 3 areas, and we hope all of you will join us in this. What learnings can be applied elsewhere? What does this mean for healthy aging strategies going forward? And which areas should the Gender and Aging Committee focus on for the next year and over the next several years? We will then also want to hear your views in the Q&A. But before we get started, there are a few housekeeping rules to go through. Internet issues may affect sound and video, so please do bear with us if this occurs. At the bottom of your screen, you will see a chat function to communicate with panelists and delegates, as well as a Q&A feature where we will be collecting questions for the panelists. In the interests of time, we would appreciate if you could keep the questions short and focus on the topics of today's webinar. If you are having any issues with the audio or video throughout the webinar, try to connect with an Ethernet cable or through hotspot on your phone. If you get disconnected from the webinar, do use the same link from the confirmation email to go back in. You're all invited to post comments on Twitter using the hashtag #WhyGenderMatters and @ILCGlobal. This webinar is being recorded and will be published for public access on our website and on YouTube channel. Presentation slides and the recording will be published the next day. Do submit your questions to our speakers using the Q&A feature in the bottom bar of your screen throughout, and join the conversation on Twitter. We will be answering your questions in the Q&A section after our panelists' presentations. Let me introduce the ILC Global Alliance. The ILC Global Alliance is an international consortium of member organizations that have members in about 16 countries. Can you show the next slide, please? So these are the different centers in all, from the US to Japan to Canada, China, Brazil. The Gender and Aging Committee was established last year by the ILC Global Alliance Board, and that aims to provide a platform to understand better the intersection between gender and aging and its implications for policymakers worldwide. Gender informs all aspects of aging, from health and care to work and pensions, and its impact can be felt right throughout the life course. The Global Alliance webinar aims to provide an opportunity to begin a conversation on gender and aging and how the two intersect to impact our health and well-being. Building on the convention, the elimination of all forms of discrimination against women, or CEDAW, and the Beijing Platform for Action for Gender Equality and the Empowerment of Women, the goal of gender equality and the principle of gender mainstreaming in an aging society was firmly integrated into the Madrid International Plan of Action on Aging, or MIPA. However, despite significant policy progress made over the past decades, gaps between men and women remain and significantly impact the quality of life in older age. There is a need to take a gender-responsive intergenerational life course approach to population aging, including 3 immediate actions that we at ILC Global Alliance Committee on Gender and Aging are putting forward. First one, ensuring gender is mainstreamed into aging policies, and aging is mainstreamed into gender policies. We are engaging in the intergovernmental and civil society mechanisms, such as the Commission on the Status of Women and the Generation Equality Forum, in shaping gender equality policies for older persons. Secondly, there is a need to reinforce and protect the human rights of older women. Recently, the independent expert on the enjoyment of all human rights by older persons, Ms. Claudia Muller, is taking essential steps towards this direction and has gathered inputs, including from members of the ILC Global Alliance, on the intersection between gender and aging and the specific human rights concerns and challenges faced by older women. Finally, the third immediate action is improving data on the interactions of gender and aging. The work of the ILC Global Alliance, and that's where we are here to present to you what we have done so far, aims to fill this gap, and this webinar hopes to give precedence to this area. Allow me then to introduce the panelists from the ILC Global Alliance family, including our main speaker tonight. We have here as main speaker, Sara Carmel. She's the head the Center for Multidisciplinary Research in Aging and President ILC Israel. Sara is a professor emeritus of medical sociology and gerontology. Since 2004, she has been the head of the Center for Multidisciplinary Research in Aging at the Ben Gurion University in Israel. Since 2007, she has been the president of ILC Israel, and she was president of the Israel Gerontological Society, and she had established the National Fund for Research in Aging. She has been an author of about 200 scientific publications, including 3 edited books. Sara, the next one we have is Dr. Elena Bendien. She is from representative of ILC Netherlands. She is a social scientist, social and cultural gerontologist, senior researcher and lecturer at the Leiden Academy of Vitality and Aging, the Netherlands. Her expertise lies in the transdisciplinary field of aging studies with a focus on life course perspective, life review, ageism, and the intersection between gender and aging. The next speaker we're going to have later as part of the panel is Liam Hanson, Communications and Engagement Officer from ILC UK. Is responsible for maximizing the impact and reach of ILC UK's project. Has previously worked within the healthcare practice of a public affairs consultancy in Brussels, where he assisted in stakeholder engagement on projects aimed at promoting prevention and active aging. 2 other panelists, the last 2, but certainly not the least, Dr. Sebastiana Kalula, co-director ILC South Africa, an emeritus associate professor and specialist physician in medicine and geriatric medicine at the University of Cape Town and the Groote Schuur Hospital. And the last, but not the least, Professor Julie Byles, head of ILC Australia, is the Global Innovations Chair in Responsive Transitions in Health and Aging, Director of the Center for Women's Health Research, and the Director of the Australian Longitudinal Study on Women's Health. She's also a fellow and life member of the Australian Association of Gerontology. So tonight we have all these esteemed speakers and presenters and researchers from the ILC Global Alliance, and we would like to start with our main speaker, keynote panel presentation by our Dr. Sara Carmel. Great privilege to introduce you to give us the keynote speech. Please, Sara.
So, good morning, good afternoon, good evening, wherever you are, greetings. I would like to thank first for the introduction, and my thanks to the organizers for inviting me to this webinar. I will talk about gender differences, but before that, I would like to present you a sentence from the US Declaration of Independence. We see here, according to this declaration, all men are created equal, and they have equal rights for life, liberty, and the pursuit of happiness. This social challenge of an ideal society was presented to us in the 18th century. And here we are today, about 250 years later, and we are going to discuss gender inequalities. I talk about the largest population group in the world, comprising more than 50% of the world population, not just inequalities among small groups. So we will talk about the group of females, and I'll present the gender inequalities in young and old age. First, I'll start with the Holy Bible citation from there, also called the Old Testament. We see immediately that there is a clear division of biological roles and social roles. Women stay at home, and in other words, women stay at home and raise children, give birth to children, and males leave home and go out to bring bread. And most societies adopted this paternalistic orientation, as I see it. And this has led to disadvantages, severe disadvantages of women in a number of dimensions of life. First of all, in socioeconomic resources, social stereotypes, health and function, well-being, and which is subjective quality of life. So what happens when people age? When people age, the division of roles changes. There are no biological roles as in young age, and also social roles change. So the question is, what happens then? There are two hypotheses, whether it will, we can see or notice a divergence or a convergence regarding the gender differences. And I'll start with the socioeconomic status. Most important factors in socioeconomic status are education and income. These two factors can enable people to change their status in society, but not just in society. It affects significantly their health and well-being. And of course, the social roles dictated by society. And I'll start with, just a minute. I'll start with the extreme sides of education. Illiteracy. Illiteracy in the age of 60 and over in the less developed countries. We see that with time, illiteracy declines, but whenever we look at it, we see that there is a gap between females and males. Women have less education than men. And here, the other extreme, percent of people who complete university level education, and we see here information of two groups. A younger generation, people aged 65 and 44, males, females, these are the brighter color are those of males, and then 55 to 64, again, males and females. But when we look on each country, and this is the first country, Australia, we see that the percentage of males who completed higher education is higher than that of women. And this happens also in older ages. But what we can conclude here is that younger generations are more highly educated. And there regarding, we see here what happens in some developed countries, and here in the developing countries, meaning that their level of education is much lower. Regarding living arrangements, because there are more males who are married than females, we see that the percentage of people living alone is higher among females than among males. And regarding, this is true for all parts of the world. And here we see the participation in the labor force. Again, we see that there is always in every region in the world, in every country in the world, more men are participating in the labor force than women. And in less developed countries, people work for longer years because this is data for people in the age of 60 and older. And then it is, as can be expected, because men work more outside than women, then we see that more of them in each of the countries, the darker color, receive employer-provided pensions. And then who provides caregiving? It is mostly women who provide care, who are caregivers. And when the caregiving tasks becomes more intensive and more complicated, the percentage of women increases to 71%. It is 40 hours per week to people with 2 ADLs. But we can see that in countries with high social protection, the burden of caregiving decreases in comparison to countries with low social protection. The percent of people involved in caregiving declines, which is very important to note. But again, the gap between female and males remains in every block of countries. And this is about health, life expectancy, types of diseases, and self-perceived health. So it is not a secret that women live longer than males and than men, and that this occurs all over the world, including in the less developed countries. But again, the gap between males and females differs in the different blocks of countries. You know, here in Israel, the gap is 4 years. In Northern Europe, it is about 6 years. And this is because, you know, Israeli women are very good wives. So, and what happens with life expectancy in very old age, about the ages of 86, 87, the difference diminishes significantly. In the age of 100, we don't see any difference at all, of course. Men and women differ in the prevalence on various diseases. Here we have information about hip fractures. Of course, the number of hip fractures is much higher among women because they suffer also more from osteoporosis than among males, and this is all over the world. Here it is about obesity. Obesity is more prevalent among women. We see it over the years in all periods of time, and we see that the bars here are higher than the bars here, and therefore we can conclude that women suffer more from obesity than males. And I would like to note that excuse me, that it doesn't matter in which period or in which stage of aging. They're always in the same stage, always women are more obese than men. So, and the obesity epidemic is, as I said, more prevalent among women, but it is also of special threat to women's health and functioning. For example, above 30% of the gender gap in disability is explained by women's obesity and only 13% by arthritis. Self-rated health, as far as I know, it is a very important measure of not just of health, but also of mortality, although it is a subjective measure. And it is men rank themselves higher on health than women. And this is interesting because it represents the level of disability in old age. We are talking about people age 60. I don't see it, but people who are older, and we see it in almost all countries. Only in the most modern countries or Western countries like Canada, UK, and the US, you see that they rank almost similar their health. But in most countries, men rank their health as better than women, that of women. We see here, for example, North America in the red colors and Latin America here. We see that the level of the percentage of people reporting good health is lower in Latin America, but then in the North America, but towards the age of 79, we see a convergence in these reports. Health and function. This is a good representation of life expectancy at the age of 65 and life expectancy with activity limitations. So the dark color are life expectancy without activity limitations, and the bright colors, the percent of life lived in these years with activity limitations. And we don't have to look, for every country and see what are the percentages. We can just look on the color, the bright color, the width of it here and the width of here among the women, and we see that the years, the percentage of years lived with activity limitations is higher in almost every country that is represented here, among women, of course. So the ADL. Women need more ADL assistance than males. Here, the dark color is of females. A higher percentage of women need assistance in ADL functions. What we see here is that not only in very old age, but in every period, in every stage of aging, we see that the gap between males and females. And this refers to IADL. Mental health and well-being. So if I summarize, women nowadays more than ever carry a heavy burden of multiple roles at home and as workers outside the home, in addition to longer and more complicated caregiving roles in the family. When changes appear in society, then there is no synchronization, and some aspects remain as they were, other aspects and roles change, and then we have this time of transition, which is very difficult in this case for many women in the world. Older women are disadvantaged in terms of education and income, and more of them live alone. They often continue with their caregiving into old age when they are fragile themselves. And the subjective evaluations of health, which I presented, across country are in accordance with the more objective data on gender differences in health and number of years lived with disabilities. In some Western countries, I have to say, such as the UK and the US, these gaps almost disappear, especially among groups of people with the highest educational level and those who maintain an active lifestyle. So the living arrangements and the fact that more elderly men are married while more elderly women are widowed bring about the situations that more women live alone, especially in Western nations, but not only, also in rural areas of developing countries where the children live to look for work in cities and leave behind their parents. Feelings of loneliness maybe therefore, or also from other reasons, are more prevalent among women, affecting their physiology, such as stress hormones, immune functions, cardiovascular functions. This is widely described in their book, Capitulo and Patrick. In old age, loneliness is associated with cardiovascular diseases, rapid decrease in cognitive functioning, depression, malnutrition, and suicide. And in a wide-scale study, Richardson and colleagues, they researched, I think, 18 countries, and they found that in most countries, women suffer more than men from depression, including in old age, of course. However, the magnitude of gender inequalities varies across countries and other socio-demographic characteristics, such as education. And women suffer more than men from loneliness. They said it. Bad mood, anxiety, stress, and of course, depression. But they also score lower on other indicators of psychological coping resources, such as self-efficacy, mastery, and control over life. Well-being subjective well-being is evaluated by a number of measures, such as life satisfaction, happiness, and women generally, not in all countries, score themselves lower on life satisfaction and happiness. And here I want to introduce the will to live to people who are not familiar with it. That's because I study it, and because I believe that in old age, will to live is an important indicator of general well-being due to the commitment to continue living embedded in it, and because of its diagnostic and prognostic values. Prognostic values, one example is that will to live precedes depression. And that will be another reason is that will to live predicts survival after 7 years while controlling for other relevant factors such as age and health. This is based on an Israeli study, and another study in Finland actually found the same things, the same result after 10 years. And no matter how I study the will to live, whether I ask about it directly or indirectly by asking about whether people want to prolong their lives when in a hypothetical condition of severe illness such as spread cancer, no matter how I ask it, the gap between males and females continues to exist. Women always want less to live than men. And here a minute about social stereotypes. You know that social stereotypes actually are the way how we perceive the world in older ages. Women suffer throughout their lifespans from social discrimination, in the family and society, paternalistic societies. This is, we call it sexism. For instance, but even in the most modern societies, when trying to move to higher positions at work, they bump into the glass ceiling and earn lower wages for the same positions. This results, of course, in lower socioeconomic status and in stress. Older adults suffer from negative stereotypes, such as they are perceived as weak, dependent, unproductive, called ageism. And therefore, they are less respected by society, which rewards only productive people, and less and more often even neglected. So what happens with older women? Older women suffer from both ageism and sexism, as well as the accumulated disadvantages in social roles, physical limitations, mental health, and well-being. So what happens in old age? I already presented that self-perceived health tends to diminish. The difference in self-perceived health tends to diminish, also in happiness, and self-perceived health continues to exist, and the difference in happiness continues to exist. And also a weaker will to live is more frequently reported by elderly women than men. So this supports the divergence hypothesis. But there is also convergence in life expectancy and self-perceived health according to some data sets and some papers. However, the gender gap in years of life with disability continues to exist between males and females into old age. So the gender paradox in morbidity and mortality. I'm sure that the raised question is, if women are disadvantaged in various areas of life experience, and they experience more mental health and functioning problems than men, how is it? They have also a weaker will to live. How is it that they live longer? And I found in the literature a number of explanations to this interesting paradox. A physiologist named Logato reported that in a book called Why Men Die First, reported that women are, she describes them, I think she's a woman, that women are physiologically more resilient than men. And we can also derive this conclusion from the fact that nature makes some kind of compensation in the sex ratio at birth, because 105 males are born compared to 95 females. Another explanation is that men suffer more from cancer and heart disease, which are key factors of mortality, while women have higher rates of chronic conditions such as arthritis, depression, osteoporosis, and fractures. And this cause, of course, suffering, but are less life-threatening than cancer and heart disease. And it is important to note that when suffering from the same diseases, such as heart disease and stroke and arthritis, women are more likely than men to exhibit disability. This is interesting. Additional explanation is that for years, smoking and alcohol consumption, which are strongly related to mortality, have been more prevalent among men than among women. And for instance, they explain 20 to 30% of the gender gap in Eastern Europe, where alcohol consumption is very prevalent among men. So I'll conclude with the negative trends of change for women in the world. Social roles as caregivers become longer in years and more complicated. Higher prevalence and risk of obesity epidemic appears among women. increase in unhealthy lifestyle, smoking and alcohol consumption. And the outcomes of these behaviors in life-threatening chronic diseases are already noticed in datasets, increase in heart disease and lung cancer. All of these appear to lead to increase in years lived with disabilities and decline in women's life expectancy. But there are also positive trends of change. We should be optimistic. Increasing awareness of the positive role of higher education and active lifestyle in health in all ages groups. This is one of the developments which is important to develop. Changes in social roles of males and females in the family are also noticed in some countries. Increasing awareness of the difficulties in caregiving and importance of social support programs to caregivers by by governments. And of course, the technological and medical developments can help women in completing some of their tasks. Also, increasing awareness about women's discrimination is important, and we see also increasing ratios of women in higher education and in participation in the workforce and in higher positions, which leads to higher income in all ages, and also to increase in standard of living. So the trends of change, the negative trends of change, we already see the first changes in the prevalence of life-threatening diseases among women, and they are rapid and direct. On the other hand, the positive changes are mainly social changes, behavioral changes, changes that are related to beliefs, to cultural beliefs, and therefore these changes, these positive changes must be strengthened in order to change women's negative stereotypes and improve their social status, health, and well-being in young and old ages. And this is not just for the benefit of women, but for the benefit of society at large, because women is comprise more than 50% of the population world. So thank you for your attention.
Thank you, Sara. Okay, the next presenters, let's hope we can keep to about 5 minutes at most for each of the presenters. So Elena, please start.
Thank you very much for invitation. And the next slide, please. Yes, I want to start. I talk today on behalf of ILC Netherlands, and I want to start with a very short remarks that give you a little bit sort of impression of the context of our research in the Netherlands. First of all, the changes on the labor market. For the first time in our history, we have the labor force that consists of 50% of women, which is very good. At the same time, we are, and we were always, the champions of the part-time work, which is still the case, but the number of women who are working full-time is growing, which is also very good. At the same time, we see the increase in the number of self-employed women, which means that their economic security is less prominent than of others. Another remark concerns the fact that the retirement age in the Netherlands is set at 67, which means that the reproductive stages of female lifespan are fully integrated now in our working lives. And we must take this into consideration when we do our research. Another remark is about mortality rates as a result of cardiovascular diseases. They are very high still among women, but it's not only the Dutch problem, it's a worldwide problem. The last introductory remark concerns what we actually understand under health. My colleagues at least, and myself, we do not really follow the WHO definition of health anymore as a state of complete health, the physical, mental health, because we don't think it's feasible actually in the modern world. So we follow the definition of positive health as the ability to adapt and self-manage in the face of different challenges. And we think that the new definition is about awareness of the health conditions, learning to live with them with as little constraints as possible. So this is the frame within which we do our research in the Netherlands mostly. The next slide, please. Now I will introduce a couple of research directions we are doing, and I hope we can explore those directions in the coming years together. The first is about the research on menopause within the context of life course. Let me say the following. There is a lot of research, biomedical research on menopause. When we tried to do a literature review on menopause and work, we saw that there is very little literature about this effect. But the literature on the consequences of the unaddressed and untreated menopause symptoms for the health and well-being of the older women in the later stages of life is actually non-existent, as if there is no connection between it. So that's why we advocate for a research on menopause in a life course perspective, when we can see what one stage in life can mean for the health in another stage in life. The next research direction is a research on all the female care workers who combine their care as professional work and informal care work. It's inspired by the work of my colleagues from Amsterdam Medical University Center, and it's about actually how all the female, especially female workers who are engaged, they are usually self-employed, and then they engage in this double care work, at work and at home. It's an interesting case actually that is described about the pandemic time, when those self-employed female workers suddenly were not protected by the organizations where they worked. They couldn't get, for example, protective means like facial masks at some point, while the personnel of those long-term care facilities did get those protection masks. So it was just such an outrageous situation that it will come back in our research, certainly. And we want to investigate how they can, self-employed, all the female workers can be protected under any conditions, because if they're not, the consequences for their health can be devastating. Another research topic. I'm not a clinical researcher myself, but in the Netherlands we have a very strong school of cardiologists, female cardiologists, who are working and trying to sort of to help develop new treatments and new understanding of cardiovascular disease. The fact is that in the last years, there was stagnation of decrease in CVD among women. So the question is why it's happening. And an interesting answer can be that you don't need only, you need not only the clinical research, you need sociological and psychological research. So we advocate for interdisciplinary research to sort of can decrease CVD among women, among which can be depression, stress, and other aspects. I see you, Susan. Two sentences here. The fourth research direction is we want to investigate what motivates older women and men after their retirement to continue work. We have some data. We have also very interesting examples like silver starters courses, where older people are sort of offered the course in entrepreneurship, and they can suggest a new idea to start anew their careers. So we want to investigate why older women, older men want to do it. And the fact tentative sort of conclusion is First of all, there are more women than men interested in such courses. And secondly, women are looking for self-fulfillment, while men are looking mostly for a new earning model. The last one, I will propose to do participatory research. We wanted to do research with older women and not about them. Thank you very much for your attention. Susan, your microphone is...
Sorry, Liam, please.
Hi, thanks very much for having me on this panel, and thanks so much for the two presenters already. So today I'm going to talk about ageism and sexism and how these two concepts intersect and affect the health and well-being of older women. So could I have the next slide, please? So I'm just going to start off by laying out what some of the key concepts are that we should be considering when we're talking about ageism and sexism. Namely, most importantly, is intersectionality. So this is when more than one identity contributes to a person's sense of self, and then how these different identities can be potentially marginalized or discriminated against. So in this example, older people may be faced with ageism, which is discrimination based on their age. Women, on the other hand, may be faced with sexism, which is discrimination based on their sex. But older women may be faced with both sexism and ageism. When we're talking about this ageism and sexism, we can talk about internal and external discrimination. So internal discrimination is when individuals hold prejudices about their own identities and modify their behavior based on this. External is when it is forced upon them and it's institutionalized. And have the next slide, please. So to kind of illustrate these concepts, I'm going to use the example of physical activity. So physical activity, we know, is a really important role in maintaining health and well-being. So a report that we at ILC UK released this week actually found that elite level athletes live about 13% longer than the general population on average. And this benefit can be felt throughout our entire lives. So even adults who increase their physical activity in their when they're aged between 50 and 60 live as long as those who are already exercising in middle age, which means that it's never too late to start participating in sport and to feel a physical and mental benefit. But women are less likely than men to be physically active. At the same time, older people are less likely than younger people to be physically active. So these two combine to mean that older women are both less likely than older men and less likely than younger women to participate in sport. As a result, as many as a third of older women are not meeting the recommended 150 minutes of exercise in the UK per week. And the next slide, please. So why is this happening? We have internal barriers, which is the most commonly cited reason for why older women don't take part in sport, is that they're not the sporty type, which means they don't see exercise as for older women. In fact, twice as many women as men cite this as a reason for not taking part in sport. And here we have that internalized ageism and sexism, that belief that sport isn't for you modifies your behavior and makes you avoid opportunities for physical exercise. We also have external barriers. And this is where that perception of what is the sporty type. So first of all, in the design of exercise spaces, there's studies that have found that open spaces like freeway areas and gyms or public parks are likely to be dominated by men. So older women don't see people like them in these spaces and assume that they're not for them. We also have in marketing, advertising, and the media. So I've got 4 examples on the screen here of adverts for home workouts. In all of them, we see younger and slim women. This contributes to the idea that exercise is not for older women. And then lastly, we have more practical barriers. So exercise takes time. And Sara and Elena have both already outlined that women are much more likely to have more caring responsibilities outside of work. So when you're juggling work and informal care responsibilities, it doesn't really give much time left for exercise. Also, we know that exercise is expensive. So Sarah's already outlined that there is a income gap between older women and older men. This means that a lot of older women may not be able to afford to exercise. So all these barriers combine with each other to mean that older women are being left out of a vital aspect of health and well-being, and that's leading to poorer mental and physical health outcomes. The next slide, please. So what needs to be done? We need to see that different intersecting forms of discrimination don't necessarily compete with one another. Actually, addressing one form of discrimination can undermine all forms. So for that reason, later this year, we're holding our annual conference, and we're going to be looking at how we can make society not only work for people of all ages, but also of all ethnicities, genders, religions, and every other characteristic or identity. So if you want to join, you can find the link to register is on the slide, or it's on our social media accounts. So I hope this presentation has illustrated some of the ways that ageism and sexism can intersect to affect the health and well-being of older women. And thanks again for having me on, and Sara for this brilliant paper.
Thank you, Liam. Sebastiana, please.
Thank you, Susan. Thank you for the invitation. And I thank the previous presenters, my colleagues, for their brilliant presentations. Next slide, please. So just to put it in context, Africa is considered as the youngest continent, where the median age of the population is about 20 years compared to the world median age of 31. However, even though the proportion of older persons is small, their numbers are increasing rapidly. Older people on the continent and in South Africa are poorly supported and vulnerable to abuse because of socio-economic situations, young people migrating, as it has been mentioned, looking for work, and this changes the support structure for older people, which was present previously. Next slide. So we know that gender-based violence is a global public health, human rights, and criminal justice problem. However, very little research and the attention is given to this issue in the low middle income countries. Even the national statistics on gender-based violence are difficult to obtain. They are not accurate, they are not disaggregated, and most incidents are not reported anyway. So gender-based violence in the older population in our society is reported as elder abuse, which, as we know, elder abuse takes different forms. Next slide, please. There have been small local studies done in South Africa that have reported high rates of elder abuse, both in men and women. The men reported mainly physical abuse, whereas the women reported more emotional, financial, and sexual abuse. And unfortunately, most of these incidents took place in a private home. Next slide. So there are the specific forms of abuse in Africa and South Africa that might not be seen elsewhere. Things like allegations of witchcraft with consequences for the frail, possibly demented, and very common among the older Black African women. And the other type is where sons, family members, threaten older women, their mothers or grandmothers with rape in order to gain access to their social pension income. And there are a variety of factors contributing to gender-based violence. Poverty, unemployment rate, for example, in South Africa is about 31–32% at the moment. There is abuse of alcohol, abuse of drugs, and traditional family structures are breaking down and changing with the migration, as we spoke about. And there is general loss of respect for older people, and the belief in witchcraft, general rates of high crime rates, and the socio-economic inequality contributes to that as well. Next slide. Within South Africa, it is mandatory to report abuse, and the older people are protected under the Older Persons Act of 2010, but the enforcement of these mechanisms are lacking. There is a government register where people committing these crimes should be registered, but this is not yet up and running. The law enforcement agencies also often fail victims who attempt to report this violence and abuse. Next slide. So the prevention of this scourge needs to be multifaceted. We need more robust research into gender-based violence. Education on the subject needs to involve everyone, men, women, families, and it needs to be community-based so that everybody is informed about the consequences of this. And the survivors of gender-based violence need to be supported to process their trauma, address depression and post-traumatic disorder. But for all this to work, the interventions need experienced staff and political will. We know that we have got August as a Women's Month. A lot of activities happen regarding that Women's Month, trying to bring up the role of women in society. And also South Africa does observe the 16 days of activism against violence against women. These politicians give speeches and the activities are held, but it doesn't seem to affect the scourge of gender-based violence at all. So really, society needs to come together to address this issue. Thank you.
Thank you, Sebastiana. I think it's my turn now to share about what's the gender differences in the role of informal caregiving in Singapore. Next slide, please. Following Sara's global study and the data, our group of researchers, our colleagues, actually, we work closely with them from the Center for Aging Research and Education, just released results from their TRACE study. It's a nationally representative study, and we can see that caregiving of older persons continues to be both a gender and aging issue in Singapore. Caregivers juggle multiple roles, which can affect their ability to prepare for old age. 74% of them are women, the current caregivers of older persons. 60% are married. 33% finished secondary level of education. 86.3% co-resides with a care recipient. 41% reported having occasionally or usually inadequate resources. And our caregivers are also aging. The average age is actually now 61.8. 86% are 50 years and above. 37% of our caregivers are actually being in that role for at least 10 years. And 53% are retired and or not working. Next slide, please. There's therefore a need to address caregiving using a gender-responsive life course approach. Informal caregiving continues to be an invisible work, particularly among women. The number of hours per week that's provided for care recipient is 33.1 hours. But between men and women, women gives 6 hours more time for caregiving than men. Caregiving has also impacted healthy aging. 1 in 3 have reported having clinically significant depressive symptoms. 34% have self-rated their health as fair, and 25.5% have at least one physical limitations. So in Singapore, we can see that really caregiving continues to be both a gender and an aging concern, and therefore needs to be addressed and mainstream in all the policies. Thank you. And our last speaker, Julie. I hope we can finish. Julie?
Yes, I'll be snappy.
Yes, thank you.
Thank you, Susana. So I'm sort of going to come back to some of the issues that Sara was talking about at the beginning, which about life expectancy, healthy life expectancy and working life. And I guess touching on some of the issues that some of the other speakers have spoken of, but talking from the context of Australia. But just having a look globally at life expectancy of women versus the life expectancy of men, this data from the UN Population Division shows the correlation between the life expectancies of women and men, and on the left there, and then we're seeing a picture on the right there showing the gender gap. And that's just reiterating what we've talked about, how there is this gender gap in life expectancy where women do live longer than men in almost all countries in all parts of the world. And the places where they don't live longer, it's generally because women have a very high maternal mortality rate. But so we are seeing this longer life expectancy in women. So that's a fact, and it's a global, almost universal fact. Next slide. But we wanted to look at not just life expectancy, but disability-free life expectancy, and to compare between men and women, to also look at the effect of education, and we heard from Sara how important that is, and also to look at the individual and combined effects of two common risk factors being smoking and obesity. So if we have a look at if you look at, for instance, the high education, and we call high education having more than or equal to 14 years of formal education compared to low education. So if you look at, for men, there is an impact of the education on total life years, but also on years free of disability. So if you're a non-smoker, non-obese man who's got higher education at age 65, you can expect to live another 20.9 years. Whereas if you're a woman with high education, non-smoker, not obese, you can expect to live another 24.5 years. So there we see that impact of gender on longer life expectancy. And that's for the best case for the most educated, the non-smokers and the not obese. And we can see the impact of education, lower education in that best scenario in terms of non-smokers and not obese, in a reduced life expectancy and a reduced number of years free of mobility and disability. So as our populations change and education rates increase, and particularly education rates increase for women, we're going to see longer life expectancy and more years free of disability. Then if we have a look at the risk factors then that we gain throughout life in terms of smoking and obesity, the main messages there are that smoking reduces the total years of life, but doesn't have a very big impact on the years with or without disability. And that's because smoking is largely related to fatal conditions. So if we think about differences between men and women, men have tended to smoke more than women. And so this might, to some extent, explain the differences in life expectancy. But of course, over the years, women decided to catch up and started smoking. So then we saw that women's smoking-related mortality increased. And we know that if women smoke like men, they die like men. But now both men and women are less likely to smoke throughout their lives and more likely to be non-smokers or ex-smokers. So in fact, the impact of that on life expectancy will be that women and men live longer, but we still have to ask the question about whether they live more years with free of disability. But if we throw in obesity, here is where we start to see the large impacts on disability, both mobility disability and ADL, IADL disability. So if we look at there, someone who is a man who's high educated, a smoker and obese, can expect to live 17.5 more life years, but only 13.6 of those years will be free of disability. If they're a non-smoker and obese, they'll live 19.6 more years, but 15.3 will be free of disability. For women, a non-smoker obese woman will live 22.9 years, but only about half of those years will be free of disability. So here we see that really strong impact of obesity on women's disability, which is what Sara talked about. And as populations get larger, older, bigger, we're going to see this greater impact in terms of both mobility, ADL and IADL disability. So next slide, please. So this is just summarising the same sort of information according to whether the men and women left school younger or older. So if we look at the older ones on the right, more years of schooling, but this is the percentage. It's showing similar information, but showing the percentage of remaining life that be free of disability. So obviously the best is to be male and not obese and a non-smoker, because there you will live a much greater proportion of your life free of disability. And the worst is to be the purple, the obese female, and even worse still to be a smoker. So that's combining there the effects of gender, education, smoking, and obesity. Next slide. I'm just going to turn briefly to workforce participation because one of the impacts, one of the assets of being healthy is being able to continue to participate in the workforce. And if we have a look at the workforce participation for men and women in later life, so looking from their 40s through to their 60s, we actually see some very different patterns of workforce participation among the Australian population of people born in the 1940s to 1950s who are now in their 60s, early 70s. And what we see for women is quite a large number of women working part-time, and we don't see that part-time pattern in men. And we see a large portion of women who leave the labour force quite early and have quite a low participation in the labour force, largely because of parenting roles and caregiving roles. And women are much more likely to have full-time participation in the workforce if they have higher education and if they are not partnered. If they're not partnered and they need to work. Whereas for men, we mostly see this pattern of full-time workforce participation for most of their lives, except for a group of men who are leaving the workforce at about age 50. And one of the major factors for them is caregiving. So we often think of caregiving as being a role for women. But in fact, when men do take up caregiving, it can have a major impact on their workforce participation and therefore their later life. So we mustn't discount the effect on men. So I'm just going to finish there with those few factors to think about. Thank you.
Thank you, Julie. So now, please, I'd like to remind those who are on social media that to use the hashtag #WhyGenderMatters and at ILC Global, and to post your questions in the Q&A tab. So we have about roughly about 15-20 minutes for the Q&A, and we have about 17 questions now here. Let me read some of the, so can I invite all the panelists to have your video on, please? Okay, there's one here specifically for Sebastiana. What would you consider as the most pressing gender issue in old age in Africa in the coming decade? Would you like to answer that? Maybe very briefly, quickly?
Yeah, I think the pressing issue over the coming decade, and this should involve a life course, is improving education. In women, because women in our society, if a parent had to choose who to send to school, they would send the boy and not the girl. And this left women as, in old age, dependent on others. The social pension that they get, 137 rands, which is a non-contributory pension covering most women, is not sufficient to make them independent, and dependence exposes them to abuse and violence. Thank you.
Okay.
of
Thank
time, maybe I'll stop there. You said brief.
Yes. Interestingly, well, there's a bit of different questions here. Let me try and, okay, very interesting stats on the will to live, Sara. This is not really a question, so this is maybe you may just want to kind of like let me choose something that's a question. Maybe you may want to read that. It's a comment from one of the participants. There's one here. Any research on how income security in old age and health are related or intersected?
Related to will to live? This is the question?
No. The question is there any research, Sara, on how income security in old age and health are related or intersected?
Well,
do you know of any?
I cannot say for sure if there is or isn't, because this is too ambitious.
I actually have some data on that, Susana, and I can report from our data that money does make you happy.
Okay.
But it's definitely associated with your mental health.
As I said in my presentations, that income, money, wealth are very important factors to social status and to power in society and to social networks, important social networks. And this is very important. I noticed it during a long physician strike of 2 or 3 months, I don't remember, in 1983 in Israel, that people, even if they are less ill, they can receive medical assistance from physicians, and they pay less for it than people in higher social class than people in lower social class. And this was very interesting for me. But anyway, income is important. We cannot just, you know.
Yeah. Let me ask you.
It is important for health in many direct and indirect ways.
Yes, you did say earlier that of the socioeconomic determinants,
yes.
Education and income are two very important ones, right? But then we find, like say in Singapore, we find that even the highest educated women at some point stop working, and they don't come back to the workforce. Therefore, income. So to a certain extent, although education, they've managed to reach a certain level of education, if they stop working, then they will not be able to have the income. So therefore, their ability to, their experience of aging would be a challenge, to continue to be a challenge, right?
Yes, because, cultural beliefs and norms of behavior play also an important role. And we cannot, forget them, because if you do a study across nations, this is one of the factors that should be taken. For example, in traditional societies, the differences between males and females are different than in the more secular and modern societies. And the status of women is higher because women do want to work outside homes. They want to change their lifestyles in a more, maybe in more poor societies, traditional societies, things are different. I just listened to Sebastiana's presentation. It's another world. We are talking about different worlds, and what differs is poverty, wealth, and traditional beliefs or religions.
Thank you, Sara. Maybe Julie or Elena or even Sebastiana can help answer this. There's a question here from Yok Fong. Aging caregivers to the frail older adult, what policies have addressed their needs? Do we know? Any experience in Australia, Netherlands?
There are different experiences, I think, in different countries.
Okay.
In the Netherlands, we don't have really the sort of official policy, only unofficial one. At some point, our government said that we are going to live in a so-called participatory society, which means that all informal care must be done by your neighbors, your family members, or whoever, and it's done like that. There is no financial sort of benefit here. But in some countries, I think in Germany, for example, you can sort of make an exchange for some financial support. So it's the choice that the government makes at that point. And in Holland, unfortunately, we don't have this. So it remains a big problem.
Yeah, in Australia, we have a caregivers allowance, but that's an amount of money that's given to the caregiver. But I think one of the problems with that is that money is not necessarily, doesn't come with any education program or skills program. So it can be subject to misuse rather than effective use to help the carer with those needs. I think there's also a tendency among people who are caregivers and the caregiver dyad, which is often a reciprocal one, to try to not require formal services and to try to hide their needs. So one of the things I'd like to achieve before I stop working in gerontology, whenever that might be, is to help people to recognize that it's important to get help and that help helps. So that's a message I try to get out there, that help does help, and it's not a failure if you need to ask for help. We've also done some research in Ghana on caregivers over there, and they do get a small allowance from the government. I can't remember whether it goes to the caregiver or the person who needs the care, but there are a lot of sort of gender issues over there about people being sort of there, and sometimes being either an internal or external expectation for the person to give care, particularly daughters, and the personal costs that is associated with that.
Okay, there's a question here. What impact does gender have on health and safety at work? Is that something we can answer?
Do you want to answer that, Susana?
I'm trying to find the question again. It's a bit tough to. Liam, is that something you can help to answer while I try and find other questions? I'm the one trying to find the questions as well.
Yeah, absolutely. Maybe less so on the safety aspect, but more on health. I think we did a piece of research recently where we interviewed older workers to see what sort of opinions they had about work. And it kind of relates to that internalized ageism thing that I said, where people kind of discriminate against themselves, and they have this view that, like I think Sara mentioned, that this idea that older workers are frail, and the idea that maybe you can't teach a dog new tricks, these sorts of things. And I think that translates into health as well, that older people, because the stereotype is that older workers are going to be too frail to work, the older workers may want to hide their health conditions from their employers in anticipation that their employer will be discriminatory. And I think for older women, that's especially true of menopause, from what I've seen, that because there is a kind of stigma around it, that older women who are in the workplace may want to hide the effects of their menopause rather than speaking to their employees about how they could be supported to carry on working. And as a result, I think that leads to a lot of people leaving the workplace a lot earlier than they actually needed to.
Yeah, and I think there's also like, what is an older worker? And I think there's a different cut point for women to men. So if you're talking about menopause, you're talking about women in their 50s. And so some of them might be just getting into their stride in terms of their career. Many women will be returning to the workforce after caring for family at that point in time. So they're ready to take off. But whereas a man in their 50s might not necessarily be seen to be an older worker, but just somebody who's moving into sort of form and material. So, yeah.
Okay, there's one very interesting. Yes, Sara.
And more women than men are involved in preventive health behavior. They are more aware of prevention than males. So it's also one of the factors that can explain how it affects health. But it doesn't help them much.
Okay, this is a question directed at Sebastiana, but I guess all of the other panelists can also answer. Life course data is challenging. Is there a plan to establish this in Africa, but elsewhere? Is there data on life course? Question from, ILC UK would like to answer this question as well. But Sebastiana?
Yeah, what the problem we have in Africa, I think, is collecting data, which I hope with the pandemic, people will come to realize that it's very important to have data, because without that, you cannot plan or see the needs that a country needs. And just to say that, Africa has got 54 countries. So it's not one place that has got one thing.
Sort of homogeneous as well.
Yes, it's more homogeneous, I think, than any other continent.
Okay, Leah?
Countries within Africa are at different levels. But the data collection is something that I hope that the pandemic and the way people had to plan for services and know which populations need what, that it will change the way, data collection is looked at.
Leah? Sorry, Leah?
Yeah, sure. I think my angle on this would probably be more frustration at the lack of consideration in policy at the impact that it's going to have on across the life course, because there obviously is, in a democracy, such a tendency and such a motivation to think about the next 5 years and policies that will be important for the next 5 years, and to ignore any data about what that effect of that policy will be on for someone, what the effects that will be on, for example, from my pension when I come to retire, whenever that will be, instead of just thinking about the next generation of retirees. I guess I'd flag that, so within the UK, in Wales, they have a commissioner for future generations who spoke at one of our conferences. Fascinating. But to kind of have a politician whose sole role is to consider what the impact of policy on future generations would be a really interesting idea, I think, for other countries.
Okay, also to add on what I said, I can give concrete examples. For example, the gender-based violence in low, middle-income countries, which Africa is, most of it. The data collection, which is not reliable, ends at 49. HIV, the epidemic, they only study the impact of HIV in the population up to 49. So after 49, you don't exist. That's the issue.
I guess in a way that also answers the question by how can we make more visible to policymakers older women's and men's economic contributions? So if some of this data stops at a certain age and doesn't include older age groups, then of course it will not be within their radar as well. So is there recommendation or proposal from ILCGA? And this will be the last question before I ask Julie to give us the closing remarks. How do we? It seems like where older women's issues are really kind of like in the list of priority between men and women, between younger men and younger women and older women. And so the question is, how do we make it more visible to policymakers? And I'll couple that with the question by Judith about, can feminists help diminish ageism directed at women? Anybody from the panel, please? Anybody wants to take it on? One or two, and then I'll pass to Julie for closing.
I would start with a general remark of academic activism. You know,
yes,
we have power as researchers, and we can use this power, and must actually, I think, should use our power to map some questions that are now implicit actually in policies. And the entire question of menopause and work in the Netherlands, we did it. I'm proud to be part of a team that sort of ensured that this question, this issue is now on the top of the policy list. And it wouldn't happen if we haven't done our work. So we have power, we can do it. And I think in that case, yes, sort of if we sort of work together, then it will become only stronger. Now, maybe too optimistic, but this is how
anybody wants to add to Elena's answer? If not, Julie, please help us to close the webinar.
Yes, sure. Well, thank you everybody for joining us and for our panelists. And thank you, Susana, for excellent chairing there, and to Sara for a wonderful presentation at the beginning, very thought-provoking. I think some of the things that we really highlighted are the importance of education, and it's not just education of children, but education across the life course, and even in adult life, where you need to learn to be an older adult and to adapt and to maybe learn new skills as a worker, maybe learn how to be a carer, maybe learn how to anticipate your own needs as you get older and how to get help. We've talked about gaps in life expectancy and healthy life expectancy, and how they're to some extent a lot partly determined by our biology, but largely determined by our behaviours. And if we're having changes in those behaviours across populations and over time, we have to sort of project our minds to thinking what that might do in terms of in some cases it might increase our life expectancy, but sometimes it might also increase our unhealthy life expectancy. So we've got to get that balance right if we're not going to drive disability and burden of disease. And then we talked about caregiving and women's role in caregiving. And I think that that's something that certainly has to be recognised and elevated and enabled. It's very important to societies that we do have informal caregivers, because we can't afford to provide all the care formally, and nor should we want to, but how do we support those caregivers and enable them to have their best health themselves? And somebody asked about exercise in the caregivers and whether that isn't sort of a substitute for other forms of exercise. And I suspect not, because I think it's a stressful form of exercise. It's not done in a way where you're getting endorphins or where you're warming up or you're getting the sort of biological, probably somebody who's an exercise physiologist could talk better than I can about that. But I think you just might not be getting the same benefits. It might be more of a stress rather than something that's sort of helping you to homeostasis is the technical term. There's a sort of good stress, whereas caregiving might be more of a bad stress in some ways. And even just women's homemaking and the roles and what that means for women in terms of their roles, their relations, their stereotypes, their power. What does that do for women, and how does that intersect between ageism and sexism? And the fact that women's work is invisible probably does diminish their status and their feelings of well-being. And then Sebastiana gave us a very compelling and telling insight into gender-based violence and how that might play out in some populations in different parts of Africa, and how we really do need to recognise that there are some women who are very vulnerable indeed, and what can we do to try and empower those women and help them to protect themselves and help their families understand the importance of protecting them and their societies to understand the value of those women as human beings and their human rights. So I think, thank you everybody for a very compelling, comprehensive and wide-ranging discussion. For the ILC, this is going to feed into setting an agenda for us in terms of what our priorities might be in terms of gender and ageing. And there's a lot here for us to work with. So thank you.
Thank you. Thank you, everybody.
Thank you.
Thank you.
Thank you.
Thank you.
Bye, everyone.